The following is a paid program. WOR's airing of this program constitutes neither an endorsement of the products offered or the ideas expressed.
Welcome, everybody. It's the Radiosurgery Show with Dr. Gil Lederman, MD, New York's only Harvard-trained, triple board-certified radiation oncologist who brings you the latest cancer treatment news, interviewing world-renowned cancer experts, delving into special cases, and, of course, answering your questions. I'm Rob Redstone, broadcasting from the WOR studios in the heart of New York City. And now, please welcome Dr. Lederman.
Good morning. Good morning, everyone. Good morning, Rob Spencer, who's my co-host today.
Good morning, Dr. Lederman.
How are you today?
I'm doing very well. How are you?
Fine, thank you. We have Eddie and Reg in the control booth, who's running this show that's making it so fantastic. Thank you again. Thanks for our listeners. We have a lot of interesting news and cases today to discuss.
And let me tell the listeners to call in. We're 1-800-321-0710. Again, that's 1-800-321-0710.
Yeah, we're a live program. We're not canned. It's no bullshit here. We're live. We take your calls. We try to answer your questions. If you have questions, you're welcome to call on air. You're welcome to call during the week. We also have a booklet and a DVD that we send out for free. So any listeners that want it are welcome to call in anytime and get that. Best is Monday through Friday. So some interesting news in headlines this week.
Oh, yeah? What is that?
Well, the people have been studying what fruits are good for you.
Fruits?
Yeah.
Fruits are good for you, right?
Well, are they good for you or not?
I hope so. If not, then I've been lied to my whole life.
Well, I think fruits are good for you. They're good for your health. And now there's a study done. What fruits are more likely to diminish your risk of having type 2 diabetes? So we don't normally talk about diabetes. We talk about mainly cancer and cancer issues. But I thought it was interesting for a variety of reasons because all the fruits that reduce or seem to reduce type 2 diabetes are the ones that are on my table, if I can find a place to put them on my table.
Okay. Which ones are those?
Okay, so what happened? So they took 185,000 people.
Okay, that's a lot of people.
It's a lot of people. How would you manage 185,000 people? The study appeared in British Medical Journal.
Good journal.
They were followed 12 years. So 12 years, 185,000 people. And of those numbers, guess how many developed type 2 diabetes?
30%.
So, well, you're talking big numbers. No,
it's too high,
a lot less. It was 12,000.
Okay.
12,000 out of 185,000. So that's about 7%.
Okay.
Something like that. And they tried to control for health factors, behavioral factors, and there were fruits like strawberries, oranges, peaches, plums, apricots.
Okay.
Didn't do anything. They didn't change the risk of type 2 diabetes. So the ones that did were grapes, apples, grapefruit.
Okay. I wonder what makes those different.
And the number one fruit, the biggest winner was?
No idea.
Blueberries.
Wow.
Blueberries
okay.
are on top of like every writ list.
Okay.
You know, they're on top. Wow, you want to get healthy, eat blueberries. Eating 1 to 3 servings a month decreased the risk by 11%.
Wow.
That's not very much.
Well, it's still something.
Yeah, but in my house, I buy 10 pounds of blueberries every time I go to the grocery store. I buy a lot. Sometimes I buy 20 pounds.
I like blueberries, too.
I love blueberries. If you have 5 servings a week of blueberries, it reduces the risk of type 2 diabetes by 26%.
Those are good numbers, I think.
Those are great numbers.
Yeah.
And if you love blueberries, it's 2 for 1.
Yeah.
Now, what happens if you take fruit juice instead of fruit?
Oh, that's not good. They have a lot of extra sugar.
A lot of sugar.
Yeah.
So fruit juice doesn't help one bit. So you got to get the blueberries, and you better do it soon. Apples are coming in season, grapes, and grapefruit. So be a lot of grapefruit in the wintertime. We'll get apples year-round, and I guess you should think about what you eat.
Yeah. It's deceiving, though, because the juices, they advertise them as being really healthy sometimes.
They advertise them as healthy. That's kind of like the story for vitamins and
That's right.
advertise. They don't advertise blueberries very much, and they're the healthiest ones.
That's right.
Why do you think that is?
I have no idea why those are the healthy ones.
Now, why do you think that the ones they advertise are not the ones that are healthy?
Because those are the ones that make them the most money.
Yeah. Yeah, because you go buy a little box of blueberries for $1 or $2. There's no, I don't know, National Blueberry Association.
Maybe there should be.
Yeah, but those companies that make the juice, and you ever look on the side of the package, it's 2% juice. So in cancer news, there is cancer news this week, and most of the show we're going to talk about cancer issues and hopefully inform you and get you better care, get you better treatment, and hopefully avoid cancer altogether. So the FDA, unlike fruit juice, the FDA is out there. Maybe they do look at fruit juice. The FDA approves drugs for safety and efficacy.
That's right.
So fruit juice is probably not there for efficacy, probably for safety only. So Abraxane was approved for pancreatic cancer.
Okay.
And pancreatic cancer is one of the big feared cancers. It's the number 4 killer of Americans. So it's a very feared cancer. There's 45,000 cases a year. So that compares to breast cancer and lung cancer to have more than 200,000. So there's substantial numbers. Of 45,000 new cases, the majority of people die. 38,000 die.
Sure. And I think that's because when it's diagnosed, it's already pretty late in the game, isn't it?
Right. So compared to breast cancer, which someone can feel, and other cancers, skin cancer that you can see, pancreas cancer is really nothing you can feel, nothing you can see.
Right.
And there's no early screening of pancreas cancer.
Yeah.
So Abraxane is a new drug. It's actually an old drug that is hooked up with albumin, which is a normal protein in the body. So it's actually Taxol hooked up with albumin, and the reason to hook it up is to moderate the toxicity of it.
Sure.
There's other combination chemotherapies that are better than Abraxane, but Abraxane got approved because it's easier to administer and easier to tolerate. What's the cost of Abraxane? Well, it's about $6,000 to $8,000 a month. So we're seeing a lot of these drugs are really very, very expensive.
That's right.
And you can understand why our health bill is being sunk with the cost of these medications.
They really are very expensive.
It's very, very expensive. It's hard to understand why they're so expensive. So anyway, Abraxane is approved. There's a new drug out there for metastatic pancreas cancer. We treat a lot of pancreas cancer with radiosurgery. And the reason is it works, number one. Number two, it's easy to tolerate. We treat the cancer in the pancreas or metastatic cancer. Our success, meaning stopping the cancer where we treat. So we speak to the patient, we decide it's in the pancreas or it's in the liver, and we do non-invasive treatment. Radiosurgery is a misnomer. It was a name that was developed by a Swedish doctor 60 years ago, but it really is a misnomer because it's not surgery at all.
Right.
It's only mimicking surgery. It's non-invasive treatment. Patients come in 15 minutes, get a treatment, and go home and usually feel nothing. The success rate's about 90% in stopping or shrinking the cancer where we aim the beam.
That's an excellent success rate.
Yeah, so it's high, and we often will treat bulky sites of disease or the primary site or metastatic sites or in patients who haven't had a good response to chemo or don't want to have surgery. So there's a lot of indications for radiosurgery for pancreas cancer.
Is there an order that you treat them in? In other words, if it's metastasized to other organs, do you treat the organs first and then the primary site, or?
Well, the way it works in America, unfortunately, is not necessarily that way. I mean, most people get referred to a medical oncologist, which is a chemo doctor.
Okay.
And then the chemo doctor usually will start treatment. Some think about radiation to try to consolidate the treatment to make the bulky disease smaller, shriveled up. Some just start treating and never stop treating, really. I would treat a patient who has symptoms. I treat the side of the symptoms first if they have pain. And a lot of people with pancreas cancer have pain because the cancer grows into the celiac plexus or the adjacent nerves.
Mm-hmm.
So we often will treat that. It's 5 treatments, so it's pretty quick.
Yeah, that is.
Same with liver metastasis, 5 treatments. So the treatments are so fast that you can actually do them simultaneously or sequentially. I usually treat the worst area first to show the patient that we can successfully treat them,
Right.
and it's easy to treat.
That's good. How do your the side effects of your therapy compare with surgery?
Well, look, surgery's open. So
Yeah.
you've got open surgery, you've got all the risks of infection, bleeding, convalescence. The surgery for pancreas cancer is a Whipple procedure, which is a radical surgery, removing the pancreas, sometimes part of the stomach, spleen, adjacent organs.
Right.
It's hard to convalesce from that. It takes weeks, months. Some people even die. I sent a friend to see a surgeon just as a second opinion because I didn't want the patient to think I was pushing them into radiosurgery.
Right.
And the patient misunderstood that I was sending him to have the surgery. He chose to have surgery. He was a 38-year-old man, and he died at one of the biggest hospitals in New York that specializes in this kind of work. So
That's sad.
surgery has lots of complications. Compared to us, I mean, if you had this treatment 15 minutes ago, you'd be on the radio show co-hosting right now.
That's right.
So it's a really amazing difference. It's like day and night. Anyway, so I wanted to bring that topic up. That's Cancer News of the Week. Also, the news of the week is about robotic surgery for prostate cancer.
Okay.
And robotic surgery, do you know anything about it at all?
Only that it involves robots.
Yeah, it's a robot. So there's a company that makes these machines. They sell for $3 or $4 million.
Mm-hmm.
And there's kind of a bidding war about all the hospitals. Do you have a robotic machine? Do you have it? Do you have it? Do you have it? So they all want to get on a bandwagon.
Sure.
So they spend $3 or $4 million. And the idea is for prostate and other cancers that instead of having a doctor's hands in your body, you've got mechanical hands in your body.
Yeah.
And you've got these mechanical hands that can cut and they can see and they have lenses and they have lights. And they advertise it that they can see the nerves for prostate so they don't hurt the nerves. So, obviously men with prostate cancer don't want to lose their sexual function or urinary function.
Right.
So it makes a lot of appeal if you could say, I can see the nerves and we can avoid cutting them, right?
Yeah.
So it means the man's going to be left intact, supposedly, right?
Right.
So you got these lenses and cameras, and it's like James Bond in your prostate, and
does sound like a movie, doesn't it?
Yeah, it sounds like a movie. It sounds so fantastic. They can see every nerve. They can avoid cutting them. You're going to be perfect. They're going to cure your cancer. Well, what's the truth?
The truth is, I don't know how I feel about machines being in my body like that.
Well, how about we look at the data? Let's look at the data.
Yeah, let's look at the data.
Shouldn't we be looking at the data?
I agree.
Okay, so let's look at the data. So I'm going to give you the data. This is a study done and published the Journal of Clinical Oncology. It's from Harvard Medical School.
Good school.
So it's a pretty good school. And they looked at men, hundreds of men that went through, 685 men who went through either open surgery, traditional open surgery, where the surgeon stuck his hands in and removed the prostate. Remember, the prostate sits between the bladder and the rectum.
Right.
And the nerves are on either side. So in front is the bladder, behind is the rectum, on either side are the nerves. So you kind of have to go through something to get that prostate out, right?
Right.
Unless you decide not to have surgery and do something, which we'll talk about in a minute.
Mm-hmm.
So the proof of the pudding is in the eating, right?
Right.
Okay, so if the proof of the pudding's in the eating, and you talk to these men after surgery, open normal surgery or robotic surgery, let's just say you're talking about sexual function.
Okay.
Okay, so sexual function, you need the nerves to function. If you lose those nerves,
Sure.
you're going to be deep sixed, right?
Yeah,
That's it. You're finished.
that's right.
Unless you do something different, not normal. We want all of our listeners to be normal and
do.
healthy.
And we want them to call in, too. 1-800-321-0710.
If they want. If they don't want, they don't have to call in. Sometimes people are embarrassed to call in.
Yeah.
Anyway, so